our code. My name is JL. I am here at Mountain View in the mother-baby unit. This is Noelia. She's at Sunrise. She's in the mother-baby unit as well. This is Milena. She is at Southern Hills in labor and delivery. Then we have Joni. She is at Sunrise in Neuro. And then we have Holly. She's also here at Mountain View in the medical ICU. We are with Nevada State University. Today we'll be presenting our Code Blue roles and implementing for your inpatient unit. So our overview, Noelia will be going over the problem statement. We have literature review, Code Blue roles, as well as outcomes, benefits, summary, and then our references.
So for the problem statement, so we have that the aim of the quality improvement project is to find an area that needs structured healthcare procedures that enable the creation and application of an action plan to improve patient outcomes in the facility. In emergency situations such as cardiac arrest or cardiac or respiratory arrest, a rapid and well-coordinated response is critical for patient survival. Unfortunately, many hospitals in the community, including Mountain View, Southern Hills, Sunrise Hospital, have a Code Blue, but lack team standardized assignment of roles, which results in 1 minute or more delayed response time, inefficiencies, and poor patient outcomes. Without structured Code Blue roles, critical actions such as chest compressions, airway management, medication administration, and defibrillation may not be carried out as efficiently as possible, potentially compromising patient outcomes. So research supports that organized resuscitation efforts, including clear team roles and communication strategies, significantly improve survival rates and reduce errors during Code Blue events. Implementing a structured Code Blue response system with designated roles, standardized protocols, and ongoing team training is essential to address the issue. Establishing these measures will enhance team coordination, reduce response times, and improve patient survival rates. So we each chose an article that can back up our key findings, recommendations, and the purpose of the study. So my first one, so literature review one, is the use of a simulation-based advanced resuscitation training curriculum, impact on cardiopulmonary resuscitation quality and patient outcomes. So the purpose of this study, it investigates the impact of simulation-based advanced resuscitation training, or ART, program on improving cardiopulmonary resuscitation, at quality and patient outcomes in the context of in-hospital cardiac arrest. The key findings of this article were improvement in CPR quality with higher chest compression rates and depths, ART training or significantly improved ART or outcomes, including return of spontaneous circulation from 58.1% to 86.3%. Better patient outcomes with survival to hospital discharge from 26.7% to 41.2%. And team dynamics and communication. The recommendations of this article were assign Code Blue roles before every shift to decrease stress and confusion, implementation of more focused in-hospital cardiac arrest, simulation-based ART, programs to enhance CPR quality and improve patient survival rates when compared to traditional ACLS training. And implement debriefing to identify areas of improvement either immediately after the code or at the end of every shift. And a quote from Young, training has been shown to improve survival to hospital discharge and survival with good neurological outcome following in-hospital cardiac arrest.
For literature review number two, the use of simulation to improve nurses' response to COVID-19 and Code Blue is the article we chose. The purpose of the study is to review the literature on the use of simulation to improve nurses' response to Code Blue emergencies, particularly for COVID-19 positive patients, and enhance their competence and donning and doffing and personal protective equipment, PPE. The key findings were that simulation training significantly improved nurses' knowledge, their response times, their self-confidence in managing Code Blue situations. They had better preparedness, better understanding of their roles during emergencies. The recommendations from the article were that further research on simulation combined with Code Blue scenarios for COVID-19 patients has an emphasizing on simulation as an essential training tool to enhance nurses' preparedness and safety during emergencies. From From Shelton, 2022, with nurses able to practice skills in a safe simulation environment that allows hands-on practice, nurses feel more confident in their ability to practice, which is associated with improvement in the quality of care.
For literature review number 3, an article that I found was named Development of a First 5 Minutes Program to Improve Staff Response to Pediatric Codes. The purpose of this study was to improve response of bedside personnel during the first few minutes of cardiopulmonary emergencies in pediatric patients. The initiative aims to address gaps in the knowledge and comfort among staff regarding resuscitation procedures. Some key findings from this article we found were that there was a significant improvement in the time to initiate chest compressions. It went down from 93 seconds to 26 seconds post-training. There was the time to epinephrine administration did not change. It remains the same, about over 5 minutes on average. However, there was a high compliance in the use of early interventions such as bag valve mask ventilation as well as backboard use. And there was a positive feedback from 754 participants, with 78% feeling more confident about performing during future codes. Some recommendations from this article was to have ongoing implementation and development of the first 5 minutes of the program, continuous education and training for nursing staff to maintain CPR proficiency and improve response times, as well as further research, of course, needs to be done into the effectiveness of various teaching methods and enhancing resuscitation skills. A quote that we took out from the article was, "Systematic and regular education of nurses is time-consuming, but it is crucial to improving outcomes of pediatric codes."
So the article that I chose was called "The Role Delineation of the Code Blue Team, a Quasi-Experimental Study during COVID-19." So the purpose of the study was to evaluate whether assigning code blue roles at the start of each shift can improve the delivery of defibrillation and medication administration, as well as improve the nurse's perception of teamwork during the code blue scenarios. Some of the key findings were team communication was improved, clearer understanding of roles by the team members, enhanced participation and involvement, more efficient conflict resolution, and less loss of situational awareness. So some of the recommendations were clearly identifying roles, as some team members may not be well acquainted with each other. Wearing visible lanyards such as these that would identify said roles. There was also to do a similar study with more of a longitudinal time frame with a larger sample size, as in the study there was only 16, but they recommend about 40. And then for the study to be carried out in different units, different specialties. And a quote pulled from the article is, "Studies have shown that clearly distinguished roles within Code Blue can improve patient outcomes by improving communication among Code Blue members and decreasing time from defibrillation and med administration."
And our final article, so finding the key to a better code team restructure to improve performance and outcomes. So the purpose of the study was to assess and improve the effectiveness of the hospital's code blue team by restructuring team roles, enhancing organization and implementing training programs, including mock codes and mock codes critique. The findings, code team organization and role clarity, improvement in code performance, enhancing confidence and leadership, reduction in time to defibrillate our patients, and sustained improvements in team satisfaction. Some recommendations from the article was clearly define team roles and responsibilities, implement regular training and mock codes, improve team communication and leadership, monitor performance and continue with quality improvement, ensure administrative and leadership support, and mock code critique after each mock code. So here we have a sheet that we are here sharing with you guys. Here is a copy if you guys want to look at it. And it's just something you guys can use after each mock code for evaluation.
When it comes to the Code Blue roles, each unit that is going to be assigned a role, we'll go over all of the roles and what do they entail. Starting from the team lead, which is usually the physician, the doctor, nurse practitioner in some cases. They will oversee the entire resuscitation process. They will make critical medical decisions, and they'll assign tasks to the team members. They'll monitor the patient's status and direct necessary interventions. They will decide on medication administration and defibrillation timing, adjust the approach based on the patient's response, and they will direct ongoing stabilization efforts if return of spontaneous circulation occurs. On to the primary nurse. Primary nurse is going to be the one whose patient will be coding. They will recognize the emergency and they will activate the code blue alert. They will initiate basic life support until assistance arrives. They'll provide critical medical history, patient history, participating events, recent medications or allergies. They will ensure IV access, communicate and coordinate. They'll stabilize the patient after resuscitation, and they'll document after.
The chest compressor is the first responder to the code. They start the chest compressions at a rate of 100 beats per minute, and then when others arrive, they can place the backboard beneath the patient. At 2-minute intervals, the healthcare professional giving CPR alternates with another healthcare professional to maintain proper, steady compressions. Airway manager assesses effort of breathing and airway patency of the patient. They determine which intervention would be most appropriate. They position the patient properly before implementing measures. They secure the airway, administer rescue meds, and provide proper ventilation rates and volume. Finally, they test ABGs to ensure patient is stabilizing.
So we also have the medication administrator. So the medication administrator prepares them and administers emergency medications as directed by the team leader. They ensure accurate medication administration and monitoring, ensure IV patency or access, or assist in IO access if the IV is not yet accessible, listens carefully to the team leader's medication requests, documents all administered medications, including dose, time, and response. The defibrillator operator, they operate the defibrillator, analyzes heart rhythms, says clear when the shock is ready to be delivered, delivers shocks when necessary, and then we have the recorder. They document actions of code, records patient heart rate before any defibrillation. They are the official timekeeper. They tell the compressor to switch every 2 minutes. They inform the team members about the last medication received, and ensures code response is complete, time and date, identifying information, obtains signatures, and completes the notification form.
So for outcomes and benefits, so a well-assembled code blue team is crucial for ensuring rapid, efficient, and coordinated response to a life-threatening emergency in healthcare. So having a dedicated and trained team increases the outcomes and benefits of our patients. So for the outcomes, rapid response to emergencies, improved survival rates, standardized emergency protocols, enhanced team coordination, reduced errors, and comprehensive documentation. The benefits to optimize use of resources, improve self-confidence and competencies, increase patient and family trust, quality improvement in emergency care, and interdisciplinary collaboration.
So in summary, a coordinated, skilled, and competent team is critical for an effective COVID management. Regular training and role assignment significantly improves response times and patient survival rates. Our QI project found that bi-monthly mock drills reduced resuscitation response from 93 to 26% reinforcing the impact of structured training. Studies also show that improved CPR quality, rhythm identification, and med administration increased arrival to discharge rates from 26.7% to 41.7%. So the recommendations are daily role assignments by the charge nurse to enhance clarity, collaboration, and efficiency. Mock drills every 6 months with a debriefing afterwards for continuous improvement. And this form is also something we thought about for that. Advanced CPR and rhythm recognition training to maintain competency and confidence. Standardized communication protocols for a streamlined response. A proactive approach ensures faster, more effective interventions and better patient outcomes.